This section offers Acumed's suggested method for implanting the anatomic radial head. For specific questions not addressed here, please contact your local Acumed representative or contact Acumed directly, either at 888-627-9957 or on the web at www.acumed.net. Radial head kinematics and articulation are important to the overall function of the elbow. By providing the patient with an anatomic prosthesis, wear on the capitellum is theoretically reduced due to the improved biomechanics and balancing within the elbow. The result is less pain for the patient and a lower chance of long-term prosthesis loosening. While there are many acceptable exposure methods, the Kaplan interval and a line from the lateral epicondyle toward Lister's tubercle, with a forearm in neutral rotation, permits the collateral ligament to be left intact. In fracture dislocations, the exposure is through the traumatic opening in the ligament complex. Proximally, the ECRL origin is released to the anterior capsule to permit direct access to the front of the radial head. Template the radial head prior to surgery to determine the appropriate level of resection. A maximum length of 17 millimeters of the radius can be replaced. This 17 millimeters includes the radius length reamed with a collar reamer in a later step. Resect the radial head with a microsagittal saw as close to the surgical neck as possible. Use the 5 millimeter awl to initially enter the canal. Starting with the smallest broach, prepare the canal for the stem. Tap on the back end of the broach with a mallet. There is a groove on the broach just above the cutting flutes that indicates when to stop. Use sequentially larger broaches until a tight fit is achieved with the broach. Select the collar reamer that matches the stem diameter determined by the broach in the previous step. Under power or by hand, ream to create a surface where at least 60% of the radial shaft is in contact with the reamer. Do not over-ream the radial shaft. Removing too much bone will cause the radial head not to articulate properly with the capitellum. Determine the correct implant head diameter by placing the resected head into the sizing pockets on the impactor. If between sizes, select the smaller diameter. Assemble the head gauge and stem gauge. The head gauge needs to be completely compressed. Insert the stem gauge into the bone canal. Starting with the +0 end of the trial gauge, sequentially increase the height by inserting the end of the gauge under the head until the dish of the head reaches the capitellum. The number on the trial gauge, +0, +2, +4, or +8 millimeters, will correspond to the neck height on the stem. It is critical that the coronoid contacts the trochlea during this process. The coronoid separated from the trochlea is an indicator that the stem length is too long. After selecting the trial head and stem, align laser marks on the head and stem and assemble using hand pressure. The stem laser mark is indicated for left and right for proper orientation. If the trial head and stem are difficult to connect, apply saline solution prior to connecting. Insert the trial implant into the radius and ensure the laser-etched line on the head and stem is aligned with the lateral aspect of the radius when the forearm is in neutral rotation. Check for proper articulation with the capitellum and the coronoid. Note that the coronoid needs to be in contact with the trochlea to ensure proper positioning of the trial. After determining the correct size head and stem with the trials, place the implant stem into the appropriate size hole in the impactor base. Align laser marks and impact the head and stem, then lock the Morse taper using the impactor and a mallet. Insert the implant into the radius using the impactor and a mallet. Ensure that the laser-etched line on the head is aligned with the lateral aspect of the radius when the forearm is in neutral rotation. A stem removal tool is available in the system if needed. Post-operative management is determined by the overall management of the elbow and limb, more so than specifically the radial head. For isolated fractures of the radial head and neck without ligament injury, early motion is commenced in flexion and extension, as well as pronation and supination. This usually begins within the first few days after surgery.